Case study by Liliana Prakasam. An 18-year-old African-American woman who presented to the clinic with a complaint of severe pelvic pain for 3 months. Past medical history is significant for having her first sexual encounter at age 14. She has a total of 5 sexual partners for 4 years. Male condoms were used occasionally. She has a history of having heavy menstruations since menarche at age 12. Her pain was primarily located in the lower abdominal region. She describes the pain as having an intensity of 9 out of 10. This problem began to develop 6 months ago, and she thought that the pain was related to PMS. The pain is becoming more frequent and lasting 30 minutes each time. She took ibuprofen with some relief initially, but no more signs of relief for 2 days. She denies fever, chills, fatigue, nausea, dizziness, abdominal distension, dysuria, urinary frequency, changes in bowel habits, or vaginal bleeding. She manifests having poor appetite lately and losing 10 pounds in 2 weeks. Patient doesn't take prescribed or over-the-counter medications. She lives with her parents. She is in 12th grade. She has never used alcohol, tobacco, or any other recreational drugs. Family history. She doesn't know of any diseases that run in the family. Her last physical examination was 4 years ago, and the HPV vaccine was declined by her parents at that visit. Review assisting. The patient denies fever, chills, or fatigue. She has decreased appetite and unwanted weight loss. She denies rashes or skin lesions. Eyes, denies blurred vision, double vision, or any changes in visual acuity. Ears, she denies changes in hearing. She doesn't complain about nasal congestion, rhinorrhea, or sore throat. Respiratory, denies dyspnea and cough. Cardiovascular, she denies chest pain and palpitations. Breast, she denies pain or masses in her breast. Gastrointestinal, patient denies nausea, vomiting, diarrhea, constipation, abdominal pain, or bloody stool. In the female system, it was discussed in the history. Neurological, she denies headache, seizures, paralysis, or weakness. She denies muscle pain or joint pain. Also, she denies hair changes. Denies easy bruising or bleeding. Objective data. Vital signs. Temperature 98 Fahrenheit, blood pressure 110/77. Heart rate 68, height 5'5", weight 174 pounds, and her BMI is 29. She is overweight in not acute distress. Her chest, lungs are clear to auscultation bilaterally. Cardiovascular, normal S1 and S2, no murmurs or palpitations. The PMI is normal. Abdomen, non-tender, and the bowel sounds are active and present in all 4 quadrants. In the gynecological examination, the cervix was very friable with multiple whitish erosions. Musculoskeletal, she has a full range of motion in all 4 extremities. No lymph nodes present. Diagnostic testing. Because she is in a childbearing age, we did the urine ACG, and it was negative. Pap smear was done against current clinical guidelines because of the risk factors that we will explain later. Sexual transmitted disease panel was ordered as well, and abdominal and pelvic ultrasound was ordered. Assessment. What are my differential diagnoses? Number 1, cervical dysplasia. Number 2, cervical cancer. And number 3, ovarian cancer. The primary diagnosis: inflammatory disease of the cervix. Plan. Pain management discussed. Sometimes ibuprofen doesn't work by itself, but when it's alternated with acetaminophen, it works pretty good. So I advise the patient to take ibuprofen every 8 hours, alternating with acetaminophen 500 milligrams every 6 hours. Patient was instructed to go to the ER if pains worsen or have a new onset of vaginal bleeding. Health promotion and health needs. Since the HPV was declined during the child well visit, we discussed again in the visit the need for the HPV vaccine. Also, she was advised to refrain from sexual intercourse. Lifestyle modification was included because she is overweight. Low-fat diet, meaning lean meats, and also adequate sleep and exercise. She was advised to follow up in 2 weeks or sooner for lab results. Referral to the gynecologist was initiated due to the severe cervicitis. Further follow-up. The Pap result came with the highest squamous epithelial tissue. So we called the patient before her scheduled appointment because of the urgency. The sexual transmitted disease panel was positive for chlamydia, and she was treated in the office with azithromycin 1 gram single dose, and the comorbidity report was faxed. She was instructed to tell the partner to come for treatment. Urgent colposcopy was initiated. So later, colposcopy with biopsy was done. The patient was diagnosed with cervical cancer. Urgent referral to the gynecologist-oncologist was initiated. Given this patient history and risk factors, Pap smear was done in a right way. Cervical cancer is the second most leading cause of death worldwide, with over 500,000 new cases each year, with a 50% fatality rate. In the United States, approximately 20,000 new cases of cervical cancer are detected each year, with an estimated of 4,000 deaths from this preventable disease. The incidence and mortality of cervical cancer is twice in Hispanic and African American population, while American Indian, Alaskan Native have the lowest rate of diagnosis. Hispanic have a higher diagnosis rate, but there are more fatalities in the African American population. This difference is mainly due to the late stage of diagnosis. Multiple factors contribute to this inequality, including differences in behavioral risk, information, and education, underlying biological variation, screening, follow-up, and treatment. A systematic review by the National Youth Risk Behavioral Survey shows higher numbers of African American women had the first sexual encounter at the age of 13. In addition, African American women are more likely to have 4 or more sexual partners in the lifetime compared to white women. compared to Hispanics or Caucasians. Also, because African American women are more than likely to live in poverty and lack healthcare insurance than any other ethnicity, their access to reproductive services are jeopardized. Cervical cancer originates from a premalignant or dysplastic lesion present at the squamous-columnar junction. The chance from mild dysplasia to invasive carcinoma slowly occurs over several years. During reproductive years, the replacement of columnar tissue with squamous cells occurs usually after birth, because the area widens and moves farther from the cervical os. Atypical colposcopy patterns that characterize an irregular transformation zone are caused by neoplastic squamous epithelium. Human papillomavirus infection is an infection that can change the process of the cervical endothelium, causing cervical cancer. It noted that infection with human papillomavirus doesn't signify cervical cancer. In many cases, human papillomavirus seems to be a necessary factor in the acquisition of cervical cancer, and in early stages, no signs and symptoms exist. Symptoms may include vaginal bleeding, heavy menstruation, painful intercourse, and bleeding after the sexual activities. In advanced stages, loss of appetite, fatigue, weight loss, severe pain, and urinary incontinence may occur. Patient education. Patient is educated regarding the role of HPV. Young women who not sexually active are encouraged to receive the vaccination to prevent precancerous lesions and in the future to prevent the spread of HPV. Routine annual gynecological exams and pap smear are the key to prevent the disease.